Hi, everyone. We'll get started in just a couple of minutes. It looks like people are rapidly joining now. Hi, everyone. If you're just joining, we're going to give it about another minute to give people time to file in. Okay, I think we'll go ahead and get started. We have a lot to cover today. But first, I just want to welcome everyone and say a big thank you to joining us for the launch of our 2022 Viral Hepatitis Surveillance Status Report. The report was made live this morning, along with a number of very helpful tools. And we're excited to tell you all about this year's findings. So before we get started, I just wanted to let you all know that the chat is disabled on this webinar. What we'd like for you to do is to put any questions that you may have as we go along into the Q&A box, and we'll answer them at the end. But you can feel free to put your questions there at any time as you have them while we present. So I'll start with a couple of introductions. I am very happy to be presenting today along with a couple of great colleagues. I'm Heather Bradley. I'm an associate professor of epidemiology at the Emory Rollins School of Public Health. I'm also the project director at HepVu, which is a sister site to HaidsVu. Both HaidsVu and HepVu are online platforms that visualize data and disseminate insights in HepVu's case, the viral hepatitis epidemic across the US. And we're presented by the Rollins School of Public Health at Emory in partnership with Gilead Sciences. I'd like to introduce my colleague, Watima Ntiri-Reed at NASTAD, who has just been a really important partner with us. For the last 2 years, HepVu and NASTAD have worked together on this report. Watchma, do you want to say a couple of words and introduce yourself?
Thanks, Heather. Hello, everyone. As Heather said, I'm Watchman Terry Reed. I'm the Senior Director of Syndemic Approaches at NASTAD, where I oversee our HIV prevention, viral hepatitis, and drug user health portfolio. And just want to say a huge thank you back to you, Heather, for all of your leadership on this work, as well as the full HepVu team and the folks over at Signal. And just really want to thank all of you for joining us and all the support you've provided related to the release of our report 2.0, and looking forward to sharing a little bit more in just a moment.
Thanks, Watchma. So I want to recognize a very important member of our team, Jessica Rothman. Jessica is a PhD student at Rollins in the Epi department. Some of you who responded to the report from the jurisdictions may recognize Jessica's name. She was the main point of contact to the jurisdictions for this survey, and I will credit Jessica together with all of the jurisdictions who responded for an over 90% response rate to this year's survey. So for 2 years in a row, we've had really great response from the jurisdictions and engagement, and that makes us feel really good about the findings that we're presenting as representative of what's going on at the local level. We're also joined by Frank Hood today. So Frank is the director at HepVu United and the associate director of policy and partnerships for the HepVu Foundation. I'll let Frank introduce himself when we turn the mic over to him. But I just wanted to say up front that we're fortunate to have Frank here. He's going to be talking about how you can take the findings from this report a step further and use them for advocacy purposes. So thanks in advance to Frank. As I said, we have a lot to cover today. As a brief overview, we've done our welcome and introduction, so we're going to move next into an overview of the concept for the surveillance status report, a little bit about the motivation for doing the report, and Watson will cover that, and then turn it back to me to present some of the findings from this year's report. Again, you can find a full set of findings on the HepVu website in the report, which was released this morning. And then we'll turn it over to Frank to talk about how these findings can be used for advocacy purposes. So with that, I'm going to turn it over to Watama.
Thanks so much, Heather. And just want to encourage you all, as Heather mentioned, that the chat is disabled, but definitely want to encourage you to write down any questions that come up or any comments or feedback that you have for us, because there will be an opportunity for you to share at the end. All right, so I will be talking to you about what informed our decision. Why did we create the surveillance status report? And so just to take you through a little bit of our thinking, HepVu and NASTAD really sought out to develop an annual viral hepatitis surveillance status report with the goal that you see on your screen before you. So we wanted to be able to, one, assess how jurisdictions across the US are measuring the impact of viral hepatitis on their respective communities, identify best practices for viral hepatitis surveillance, and highlight areas in need of additional resources. And so just to give you a little bit of background on the report, our first report was released last year. And similar to this, we did briefings and made sure that we made stakeholders aware of the report. And that report actually focused on 2021 and utilized findings from about 15 surveillance indicators. This was all informed by a steering committee, which I'll tell you a little bit about in just a moment, but a steering committee of experts across viral hepatitis and, of course, leading epidemiologists. And that was our baseline year. So this was prior to implementation of activities under the Center for Disease Control and Prevention's Cooperative Agreement 21-2103 for hepatitis prevention and surveillance that expanded funding from 14 to 59 jurisdictions in the US. And we knew from the beginning that the real insight was going to come from future reports. So that was our baseline. And now today we're excited to release our first annual update, which will facilitate us in monitoring when there are changes and improvements in surveillance practices in jurisdictions, which, as you'll hear from Frank, is so critical, not only for us to use within our respective jurisdictions and for our national surveillance purposes, but also when it comes to identifying additional resources for hepatitis programs. A part of what we want to make sure to do at this point in thinking about the background is just really thank all of the people who were so critical to us being able to develop this report. We want to take a moment specifically to thank the jurisdictions that responded to the survey. A number of these jurisdictions are also represented on our steering committee, but we had a huge response, which you'll hear from Heather about in just a moment. And the report really just would not be possible with these folks. These are really, really hardworking programs, don't have a lot of time, limited capacity, but took the time to complete the report. And so we really want you to know that this report is for you. It's not just that you provided this information and we're going to use it elsewhere. We also want it to support the work that's happening within your respective programs. And it demonstrates for you how much work you all do with so little resources and where we should be supporting you even more. We also want to thank the CDC. They also have been a part of this process and very supportive as we've developed these reports. So for the inaugural version of the surveillance status report, we had 4 main goals. 1, benchmarking the state of viral hepatitis surveillance in the US, and that was prior to CDC funding dissemination. Also establishing a baseline so that we could monitor changes over time as additional resources are allocated. We wanted to be able to assess how jurisdictions across the US are measuring the impact of hepatitis on their communities, as well as highlight areas in need of additional resources. So that was 1.0. Now going into the surveillance status report 2.0 for this year, which looks at 2022, we really wanted to be able to expand on last year's insights with deeper information on the capacity of hepatitis surveillance programs to do case investigation, data matching, work on their elimination plans and goals, including developing them and then implementing them. Also looking at disparities in your capacity to capture and analyze demographic data, and really just looking at dedicated capacity overall. So how much staffing capacity you have to do your surveillance work, as well as what type of funding you have available to you. And we really also wanted to highlight that from last year, coming into this year, we really took your feedback to heart and really integrated that into the types of questions that we asked going into the 2.0 report. So then finally, you might ask, you have a good sense of why we decided to move forward with this, but then there's the question of the why now. So before I get into that, just want to acknowledge there's a lack in our nation of robust surveillance data, and that limits our ability to monitor the progression of disease and our overall disease burden, to track changes in the epidemic, to mount effective public health responses, and overall, it affects our capacity to eliminate hepatitis C in the United States. The why now is that in 2021, CDC released funding for viral hepatitis surveillance across the 59 jurisdictions. So it was a perfect time to say, let's look at where we were prior to having those types of resources, and let's look at where we are now that we've been able to scale up resources, thanks to the CDC's initiative. Also, the surveillance status report will allow policymakers and other stakeholders to benchmark the current state of viral hepatitis surveillance in the US, which is so absolutely critical to the strides we're trying to make. Annually, it will monitor changes over time as federal resources are allocated so that we can see, as we scale up resources, which is the absolute goal, how we're able to effectively implement that within our programs, our surveillance programs. And then also we want to be able to, of course, monitor change over time, which will help to demonstrate the continued needs for funding, staff, and support for our viral hepatitis surveillance programs. And then, of course, there's the how. How did we get here? How did we do all of this? We did it by working in close collaboration with our comprised of state and local health department representatives, many of you on the line today, national policy and advocacy organizations like NASTAD, like HepVu Foundation, also researchers, and HepVu and NASTAD really work together to develop the set of indicators for assessing surveillance practices in the jurisdictions. And the plan is that each year we will continue to collect data from jurisdictions on these indicators, analyze the results, and prepare an updated status report to describe our findings nationally and by jurisdiction as well as regionally. All right. So before I hand things back over to Heather, as you can see, there are a number of folks that we would like to thank. So many people were involved in the success of being able to develop this report and bring it to you today. I won't go through and name everybody, but I will ask you to just pause for a moment and take a look and read through, because we really do want to give great thanks to everyone who participated in the success of this report. And with that, I will hand things over to Dr. Heather Bradley.
Thanks, Fatima. So I am in the fortunate position today of being able to share with you some of the findings from the report. Again, please go to the website and look at the full report, but I am going to highlight some of our sort of top line findings today. So sort of continuing along the lines of how did we come to have the data that we're presenting today? As Fatima said, we work closely with the steering committee all the way from creating the questions for the report to interpreting the findings. We had a 92% response rate thanks to the jurisdictions who responded, and we in the report this year, we ask about the 12-month period from 2022. So each year we ask retrospectively about the previous calendar year. So that all the findings that you'll see today are really representative of 2022. We analyzed the data at Emory with a lot of work from Jessica, and then prioritized the findings to highlight in the report together with the steering committee. You'll see some comparisons today. We're going to look at overall findings, but also findings that compare jurisdictions who received prior viral hepatitis funding prior to 2021 or did not, who had at least one full-time employee dedicated to viral hepatitis surveillance. And we also have in the report some comparisons by region. So for those of you who are familiar with last year's report, we start the report out by sort of level setting on what is viral hepatitis surveillance. We do this because we really want this report to be usable across a broad range of stakeholders, including policymakers who may not be familiar with why surveillance is so important. And so we really, here we lay out what kinds of questions can be answered by robust surveillance. Questions like how many people have current diagnosed infections? What are their characteristics? How many people have received treatment? And so what we're trying to get across here is that we rely on these data to tell us very important and core epi indicators, like what is the burden of viral hepatitis and which groups of people have increased risk for viral hepatitis infections. Again, this year we do a comparison between viral hepatitis surveillance resources and HIV surveillance resources. And we do this to show, that not all infectious disease surveillance systems are equal. We explain a little bit about the HIV surveillance system so that readers can see what is possible with adequate resources, where you may have multiple data sets that are linkable, and you can really answer critical questions about how many people are diagnosed, have increased risk, and are receiving care and treatment. So moving into the findings now. As Fatima said, some of the findings that you'll see are year-over-year findings, and some of them are questions that were newly added for this report. So one of the improvements that we were really excited to see is the percentage of jurisdictions who had at least one full-time employee dedicated to viral hepatitis surveillance. So in 2021, 68% of jurisdictions reported they had at least one FTE dedicated to core surveillance activities, and that increased to 80% in 2022. On the flip side of that is that there are 20% of jurisdictions who still don't have at least one FTE dedicated to viral hepatitis surveillance activities. We also asked this year about how many FTEs jurisdictions felt they needed to run a robust surveillance program. And what the jurisdictions reported is that they feel that they need 3 to 5 FTEs on average to perform really core surveillance activities. So lots of need for improvement here, but also some important improvement just since last year. So in terms of elimination, we saw some excellent improvement here as well. The number of jurisdictions with viral hepatitis elimination plans increased from 43% in the baseline year to 70% in this report. However, and this is another area where we just dug a little bit deeper this year, we found that only 35% of jurisdictions actually have public elimination plans, and only 54% are implementing those plans. We also ask about capacity to make progress and to measure progress, which, as we know, is so important. So in 2022, only 30% of the jurisdictions reported having capacity to make progress toward their elimination goals, and 33% had capacity to measure progress toward those goals. So just about a third are reporting that they feel they can actually make progress toward elimination goals and measure it so that they know how they're doing, right? Importantly, only 3% of jurisdictions said that they were able to make progress toward elimination goals at current levels of funding from CDC for hepatitis surveillance. So this is just national funding. It doesn't include state and other sources of funding, but this is a really, I think, important finding that this will be very usable for advocacy efforts. Moving on to data dissemination, again, we saw some great improvement here. The percentage of jurisdictions producing viral hepatitis annual surveillance summaries increased from 55% in 2021 to 65% in 2022. Again, on the flip side, we still have just over a third of jurisdictions still not producing annual surveillance summaries in 2022. And we know that these activities depend heavily on not just current funding, but previous levels of funding in terms of capacity building as well. So when we look at data dissemination among jurisdictions who had funding prior to 2021, or were newly funded in 2021, we see some pretty big differences in terms of the percentage who were able to produce surveillance summaries. So a full 85% of jurisdictions who were previously funded produced surveillance summaries, which is very encouraging, versus 59% who were not funded prior to 2021. We actually see this as a sign of encouragement because, you know, as these jurisdictions continue to be funded, we hope that this gap will start to close, and that with year-over-year funding, jurisdictions will be better able to do these core activities like producing surveillance summaries. So we also ask about jurisdictions' capacity for creating estimates or summaries of the number of hepatitis B and C cases in their jurisdiction, and separately ask about the ability to create prevalence estimates. So the prevalence estimates are more complicated because this requires data matching against registries like death registries, having an understanding longitudinally of how many people have been successfully treated or cleared their infection. And so this requires quite a bit more capacity to get to the prevalence estimate. So in 2022, 69% of jurisdictions produced or summarized the number of hepatitis B cases reported to their jurisdiction, but only 15% were able to produce hepatitis B prevalence estimates. We saw more jurisdictions producing annual estimates for the number of hepatitis C cases compared to B in 2022, so 83%, but only 20% produced hepatitis C prevalence estimates. And I just want to underscore what you all on the line probably already know, but these prevalence estimates are so key to allocating resources appropriately, to understanding what groups are at highest risk of viral hepatitis infections, and really for monitoring success of elimination plans and resource allocation over time. And so we would really, hope to see in the future that the percentage of jurisdictions who are able to produce their own prevalence estimates, it really increases. So bringing this all together and comparing these estimates by the number of or jurisdictions who had at least one FTE versus did not, we see in the orange line here, you're seeing the percentage who produced annual surveillance summaries compared by levels of FTE, the numbers who produced an estimate for the number of Hep B cases and C cases in red, and then in purple, the percentages who produced prevalence estimates for Hep B, and in turquoise for Hep C. So you see a drop off definitely between the percentages producing sort of summaries of the number of cases reported and prevalence estimates. But across the board, we do see that jurisdictions with at least one FTE are able to do much more in terms of disseminating data, analyzing and disseminating data. And so again, this gives us a lot of hope that that first, even jurisdictions without at least one FTE are doing incredible work here. But also that as resources are increased over time, and we see more capacity at the state and local levels, that we'll start to see a lot more analysis and dissemination of local burden of disease estimates. So what about case investigation and contact tracing? Case investigation, here we're referring to the ability of jurisdictions to assess whether reported cases are likely to be acute or chronic. And by contact tracing, we're referring to the ability of jurisdictions to contact people with suspected new infections and get information on their partners or other people potentially exposed. And then to contact those folks to say that they may be at risk for hepatitis B or C infections. So we definitely saw differences in the percentages of jurisdictions who were doing case investigation versus contact tracing. But over time, we saw that case investigation capacity was relatively stable. So in both years, about 80% of jurisdictions either reviewed medical records or contacted healthcare providers if they had a suspected acute new Hep B infection. And then about 70%, just over 70%, reviewed medical records or contacted providers when they thought they might have an acute or new Hep C infection. In terms of contact tracing, in 2022, nearly half of jurisdictions reported doing any contact tracing for Hep B, but only 19% contacted people potentially exposed for more than 50% of their acute Hep B cases. So we do see that when we ask about the amount of contact tracing that jurisdictions are able to do, this is really 49% is a high estimate, and only 19% were able to do contact tracing for more than 50%. The same thing in Hep C, about the same percentage of jurisdictions reported doing any contact tracing, but here only 11% were able to contact people potentially exposed for more than 50% of suspected or probable acute cases. So in terms of pregnancy status, we know that pregnancy status and perinatal transmission of both hepatitis B and C are preventable and avoidable, and it's something that we really need to be able to understand using surveillance data. And yet in 2022, only 71% of jurisdictions reported pregnancy status being a reportable condition alongside HepB cases, and 46% of jurisdictions, so quite a bit fewer, reported that pregnancy status was a reportable condition alongside hepatitis C cases. Another new area that we explored this year was jurisdictional ability to assess and address health disparities. So we asked basically about a number of different health disparities that we know exist by risk factor, by race, ethnicity, by urbanicity, sexual orientation and gender identity, and birthplace. And you can see that the ability of jurisdictions to assess and address these disparities using their surveillance data varies a lot across these disparities. So 61% of jurisdictions reported that they were able to assess and address disparities by risk factor, but only just over 50%, unfortunately, were able to really use their surveillance data to assess and address race ethnicity disparities and disparities by urbanicity. The lowest percentage here is that 28% of jurisdictions reported that they were able to assess and address disparities by birthplace, which, as we know, is extremely important for hepatitis B in particular. Again, we see that capacity matters, right? So on the left part of this graphic here, you're seeing the ability to assess and address health disparities specifically by race and by risk factor among jurisdictions who had at least one FTE and those who did not have at least one FTE. And we again see that the percentages who are able to use their data to look at disparities and to act on them is quite a bit higher for jurisdictions who had at least one FTE. And on the right, you're seeing the same graphic here, but this time by jurisdictions who had funding prior to 2021 or did not. Again, the funding prior to 2021 is really important here because it means that jurisdictions have had longer to really build capacity to do these things. And so we're really excited in the future to see some of these disparities between these groups close as jurisdictions continue to receive resources. Another new area that we added this year was a focus on syndemics. So, and we saw an important improvement here in terms of the ability of jurisdictions to match their viral hepatitis surveillance data with other data sources. So that was 68% doing any data matching in 2021 and a full 83% doing any data matching in 2022. Specifically in terms of infections that are syndemic to hepatitis B and C, we saw that 60% of jurisdictions were able to match viral hepatitis case reports with HIV surveillance data, and 37% were able to match hepatitis case reports with STD surveillance data. So again, just a really important core surveillance activity to help jurisdictions understand where these infections are co-occurring. So the summary points from these top-line findings that I've shown today are that, number one, jurisdictions are undertaking many critical viral hepatitis surveillance activities with limited resources. Even jurisdictions who had only received funding for 1 year prior to the activities that they reported in this survey really are doing amazing, given that they've had funding for surveillance from the federal level for so little time. The data, of course, suggests that prior funding and having at least one FTE dedicated to surveillance activities improves jurisdictional capacity for surveillance substantially. And so knowing that gives us a lot of hope that we will continue to see improvements across the board as we continue to do the survey. You'll see a number of recommendations in the report. The first is around investing in core surveillance infrastructure, like data systems and data science staff, right? So the second is going to be required actually for those investments, which is an increase in federal and state funding for viral hepatitis surveillance, which we know is so critical. And we're going to hear from Frank next about how you might use these findings to advocate for this additional funding. The third recommendation is really to target surveillance resources to understanding what groups have the highest risk for viral hepatitis infections, and using those data through a health equity lens to really start to reduce some of these disparities. And then last and related is just, a recommendation to prioritize, again, dedicating resources toward data collection and analysis of health disparities in a way that can really move programs forward and reduce infections in populations that have the highest burden of disease. So just a couple of wrap-up slides for me on next steps. Go to HepVu.org and you will find all of these resources already posted. We have a full user-friendly report. It's a longer version than last year with more findings, including some of the year-over-year findings that I shared today. We've also produced a shorter piece, which is really meant to be used for advocacy purposes, and it's targeted toward taking it to the Hill and to policymakers and communicating these findings in a way that resonates. And as usual, we have a full set of infographics that we hope you all will take and use in your own presentations and your own work. These are all downloadable. We have and we'll be continuing to produce a series of Q&A blogs around the findings in the report. And then we're going to be doing on our social media, as well as the social media of our partners, some amplification for advocacy efforts. So if you go to the website today, you'll see some sample tweets. Would love to see you all mentioning the report on social media. And we'll continue to reach out to all of our great partners, many of whom are on the line, to see how we can continue to amplify these findings. So we are in November now. In October, we finished the report, and we actually did an early release presentation yesterday, which was very well attended by state health departments across the country. Of course, today is the public launch of the report, as well as this webinar, and we'll be promoting on social media channels, and have also released a press release. And then we will be starting the next survey next month. So a lot of work goes into this. We do a lot of preparatory work with our steering committee to make sure that we're asking the right questions, asking them in the right way before the report ever, even hits the field. And so, we'll be starting that process with our steering committee probably as early as later this year, to make sure that we can continue to get these reports out in a way that is impactful and timely. So I'm going to turn it over to my colleague, Frank Hood, now, who's going to talk about how we might all use the report released today for viral hepatitis advocacy efforts. Thanks, Frank.
Thank you, Heather. Could I actually get 2 slides after this one? I realized I think we doubled up title slides. Yeah. All right, we'll start here. Thank you for that, Heather. I am Frank Hood. I have 2 job titles. One is with the Hepatitis B Foundation, where I am their Associate Director of Policy and Partnerships. In that role, I do oversee a lot of our state and federal advocacy around hepatitis B, as well as other hepatitides. I really do feel like the viral hepatitis advocacy space has worked in a endemic way, not only with each other, but with our HIV and STD colleagues as well. So we really are focused in a endemic way among our various advocates. One of the things that the Hepatitis B Foundation over its history has realized, though, is that in order to eliminate hepatitis B, we really have to tackle it from all sides. And one of those sides is creating a space for those doing the work to come together and share best practices. And so my other hat is as director of HepVu United, which is a coalition that is co-chaired by the foundation, as well as the Association of Asian Pacific Community Health Organizations, also known as APCHO. And we've been around, the coalition's been around 12 years now, and we are a coalition of coalitions, we like to say. We're a national coalition that brings together state and local coalitions that are focused on hepatitis B. This can be coalitions that are focused on a specific community that hepatitis B disproportionately impacts, or an organization that primarily focuses on hepatitis B. So we really work to bring folks from across the country together in order to share these best practices about how to do screening and vaccination, and really go after the different areas we need to eliminate the disease. We also do a lot of capacity building. So we really are trying to educate and everything else, but we do know that one of the things we have to do is educate our policymakers, and when we do that, it's called advocacy. So really, when we go in and kind of make a pitch as to why they should give us more resources, which generally comes in the terms of money, but can sometimes be in terms of maybe easier regulations or other things. But in general, we have to go in and kind of weave the message in a story, a way that hooks them, that gives them the information they need, and really addresses why it's important and what they can do, all in a very short period of time. So I'm actually I have 3 slides that I'm presenting, and these 3 slides really kind of go through how I would go about tackling this issue using this report. So first off, we really got to level set where we are with hepatitis B in the U.S. right now, and this is interesting in that hepatitis B and hepatitis C have the same number of people potentially living with them in the U.S. And some of that crossing over. So there's, we believe, 2.4 million people living with hepatitis B in the U.S. We believe that number is similar for hepatitis C. Really, COVID has impacted the public health infrastructure writ large, and that really has shown up within hepatitis B screening. We had a pretty consistent plateau, even though this disease is vaccine preventable. We had a pretty long plateau of about a decade, where we averaged between 20,000 and 22,000 new acute cases a year. And now, since COVID, we've really seen the number of acute cases drop quite dramatically. And then again on our most recent surveillance report, which is in 2021. So we know that less testing was happening, but that also means we've now identified fewer cases. And that's also, though, could be perceived as being, oh, hey, hepatitis B is less of an issue. And we don't believe that's actually the case. This is a disease that disproportionately impacts quite a few priority populations, and I've listed some here. We do have a kind of unique scenario where many of our priority populations are based on where they were born or the racial or ethnic community into which they identify, and that has long been the case. But we also now see a rising risk factor among people who use drugs, which is a behavioral category, not a like racial or ethnic kind of classification. So how you sort of approach those, or who might be interested for one reason or another, will vary based on what population you're really focusing on in your conversation. Something that we're working hard to raise the awareness of overall is that it's important to know who has hepatitis B and the burden of hepatitis B in an area, because you want to treat it. And of course you want to treat it, but the more kind of important thing for folks to realize is that if you don't treat it, it can lead to cancer and liver disease, and that it is that hepatitis is one of the, hepatitis is the leading cause of liver cancer worldwide. Whether it's B or C, you can parse it out. And so really identifying and vaccinating against B, or ensuring folks who have hepatitis B are treated. And this is an area, hepatitis B is similar to HIV in that U equals U. You've now then prevented someone from progressing to liver cancer or from spreading the disease. So really is treatment as prevention, but folks don't, folks are like, oh, well, then you get hepatitis B. No, you could have liver cancer and die. And the liver cancer rates have only recently started to decline. And recognizing that this is an issue and we need to do more to raise the public awareness around this, CDC and others have recently made changes to their screening regulations and their vaccine guidelines to help try to push this along. So that sort of level sets where we're at. Then if we take this report and say sort of some of the themes that get pulled out of it, there was one that really stood out to me. And for those of you who were on last year's webinar, I did an example about a cycle. And again, this year, I feel like another cycle emerged kind of messaging wise out of this report. So if we can go to the next slide. So I really feel like we have put ourselves as a sort of public health infrastructure, put ourselves up where we're setting our states up to fail. We have long known, and well, I guess I will say I have known for the 8 years I've been in this, that we are under-resourced, but I was told by those who've been here much longer than I that it has been a chronic issue, not only about public health writ large, but hepatitis is chronically underfunded, and that results in fewer people and fewer programs those people can do. So we start up with just a lack of money. As this report shows, we are now we are having states that leave gaps either in case estimates or aren't producing surveillance reports. And so tests might be coming in, but they're really not getting assessed or analyzed. And when we look at which states are doing it versus which ones aren't, it's very clear that the ones that don't have a full-time employee are the ones who aren't able to do it. And so there is clearly a capacity issue. So now all these states are getting funded. They might not have a full-time employee though, but they have to go create a plan. And technically this is an unfunded mandate. So they have to make a plan in order to have this receive this funding. But they're now creating this plan without potentially a clear or a crystal clear picture of what the problem is, because they haven't had the capacity and ability to go or the resources to go and produce the surveillance reports or to analyze the data, because there hasn't been the people there. With that though, then you're creating a plan, and it really varies from state to state, but some states won't allow you to produce a like official state document unless it goes through a certain like clearing process with community buy-in, public comment period, ability to go through different committees. And so if someone who has working on this is half of their job and they have to put together this big plan, and someone says, well, it could be like internal use only and that'll check the box, you've now gone and created a plan that isn't public that we've seen in the data. And it might not be because they're trying to do something shady, but it does create a lack of transparency. And it creates a lack of ability for the community to buy in. And when you don't let the community buy in, it really ticks them off. But it also means that they're not trying to necessarily promote it themselves, and may actually be actively working against it because they believe it should be done different. And it's not because, I'm going to assume it's not because the person sitting in the state is being like, ha ha ha, I'm going to screw over those viral hep people, even though I'm working in that division, right? Like, no, obviously the folks doing this work are trying their best, but if they have 3 persons worth of jobs to do and only half the time to do it, some things aren't going to be the way we'd like or be as good as we'd like. So if we don't have a public plan, we haven't gotten community excited, maybe are working against it. Now policymakers and leaders are like, I don't see why this is something I need to prioritize. And then we get right back to the beginning where another year we're not getting funding. So I sort of simplified it here and weaved a little tail, but the reason I weaved it, we move to the next slide, please, is because it's there. And I could actually pull out some of these different boxes and replace them with other things, and it still tells it really kind of succinctly, but those jurisdictions that have full-time employees are able to do surveillance reports in a way that those without don't. Jurisdictions believe that they really do need 3 to 5 full-time employees to truly do the surveillance activities that they're being asked to do. So they're telling us they need help. We're seeing that there's growing capacity, or at least some more capacity happening around the annual estimates, but to see only 15% prevalence estimates, I think Dr. Bradley did a fantastic job explaining why it's important for us to have prevalence estimates. And this doesn't even touch on doing case follow-up. So, we're barely doing prevalence estimates. We're not necessarily doing follow-ups to or contact tracing. So just really dropping some low-hanging fruit opportunities. And then, as I said, those who have had an elimination plan have really been able to do it because they've had dedicated staffing to be able to do it up to this point. But again, to my prior point, and I really made sure to pull this one out, because this is the one that really worried me the most, is that only a third of the states have a public plan. And that's, as someone who's worked on quite a few states plans, but particularly the last 8 years of any sort of plan the federal government has tried to do around this and opened a comment period on, that's really scary. And the only half implementing plans, that's not great. But there's also something to be said about, well, if the plans haven't been put together well, we don't know what's in the plans, is that bad? And it is. I mean, we shouldn't have had that question. We'd rather it be a place where everyone feels good about the plan and we can get buy-in. But it does show us in an advocacy sense that, here at the end, about 25.7 million, that we really are asking our states to do something that they are not resourced to do, and that needs to change. And I don't think it's the folks who are doing that job who's necessarily the ones at fault. I think they're doing their best. It is the ones who are supplying them with the resources and capacity to do it, who are usually policymakers, which is why we need this advocacy. But if we can move to the last slide, please. So that's the kind of ugly cycle we're in, and Heather pointed out quite a few good moving aheads. Looking at it from sort of this lens specifically, and as someone who has been a part of the steering committee from the beginning, I'm really thrilled about the more specific data around Hep B and Hep C. But it really does scare me that so many states aren't able to do some of the most, as we saw with COVID, especially some of the most basic and important aspects of public health, which is contact tracing and follow-up and ability to create prevalence estimates year over year. So really just, it was great to shed a light, but kind of sad to see how much work is left to be done. And I do think, though, that this report 3 or survey 3.0 could do well with differentiating what is in these viral hepatitis elimination plans, because we have seen states call their elimination plan a viral hep elimination plan and then not have a mention of B in it. So I do think this is a great report to use for advocacy, and I'm hopeful that in moving forward, we're able to get even more granular, where we can go and kind of push around ensuring that states are actually using their resources more equitably to address all viral hepatitis, not just C. And then lastly, this is just I think this is not about one in particular occurrence within government or history. We've just seen continual chipping away at public health infrastructure, whether it's winding down of funding or regulations or Medicaid coverage or some other pieces. And that all sort of adds up and might have just ripples that might come across our ponds as well. And so just continuing to think and counter, and as we have the ear and attention of policymakers mentioning that, healthcare isn't in a silo, and so their attacks or cuts on one area might indirectly or directly impact your areas as well, and that they should consider that. And with that, I believe we move to Q&A. All right.
Sorry, I forgot to unmute.
No worries.
Thank you so much, Frank. And really just want to drive home the point that the purpose of this report is obviously to inform our own knowledge as individuals and leaders working on infectious disease response in our nation, in particular viral hepatitis response, to inform our work, but it is also very much to inform our policymakers, our decision makers, both at the local, at the state, and at the federal level, to inform the efforts that they're making decisions on, and largely uninformed a lot of the time. So this is an opportunity for us to really make sure that they have the information they need to provide additional resources to viral hepatitis. So thank you so much for the work that you do, Frank, and to all of our advocacy partners who are joining us today. So with that, it is time for us to transition into our question and answer period. We've already received a few questions and want to encourage folks to continue to send your questions in. And let's go to our first one. It seems that contact tracing and follow-up work with those who are identified to have viral hepatitis, and now the CDC, it seems that contact tracing and follow-up work with those identified to have viral hepatitis, and now the CDC recommends newborns exposed to viral hepatitis be monitored. This is in reference, of course, to the recommendations that were just released by CDC on hepatitis C monitoring amongst newborns, or for perinatally exposed, any recommendations and how states, districts, and territories will be able to manage this added follow-up population. I can kick things off in response to this question just to say that I think something that this report highlights is that we're pretty limited in the resources that we have to be responsive to this. I think that CDC is aware of that, but also that this monitoring is not just happening at the health department level, it's also happening at the clinical level. And so, of course, we want to be working with our clinical partners in order to be responsive and implement the updated recommendations from CDC. But without question, on the public health side, there will be challenges when it comes to being able to monitor, given the limited resources that we have related to surveillance, and specifically our capacity for case investigation and contact tracing. So do appreciate that consideration, and that's definitely one for us to keep in mind going into the next iterations of this report. Another question we have here is, any plans to start addressing hepatitis Delta here in the US? And I'll see, I'm happy to quickly chime in on this, and then I'll see, Heather, if you have additional thoughts. There is a lot of work underway around hepatitis Delta in the United States. Actually, Frank's organization, Hepatitis B Foundation, has been leading a lot of the efforts around advocates to increase access to information on the need for increased screening and treatment for hepatitis Delta, particularly its impact on people specifically who are living with hepatitis B. There are additional efforts that are happening across organizations as well as by clinical researchers to increase our capacity to respond to hepatitis Delta in the US. So yes, there are increased efforts, but this was not something that we specifically looked at for the purposes of this report. I'll go to the next question. Do we have an example report with... Oh, sorry. Yeah, sorry, Frank.
I was gonna jump in and say, we don't have great testing around Delta either, which makes it tough to do surveillance. And Delta provides a really interesting advocacy opportunity in that Delta is a rare disease in itself. In fact, it has a rare disease classification in the US because it impacts less than 250,000 Americans, individuals in the US. But it is someone living with hepatitis B, which is a much larger community, 2.4 million in the US, 300 million worldwide, have the ability to acquire hepatitis D. You have to have B in order to acquire Delta. So it is a rare disease that can impact quite a large group and can be scary for quite a large group. Delta, though, is also preventable by the hepatitis B vaccine. So if you get vaccinated for B, you're prevented from D. And because it has rare disease status, any treatment for it is going to be classified as an orphan drug. So Delta is this whole policy, regulatory, advocacy mess, but also opportunity.
Completely.
And I could just maybe add one thing there too. I think from the HepVu standpoint, we're very interested in sort of incubating and providing information related to hepatitis Delta. I do think, as Frank just said, we're more challenged by the lack of surveillance data and other data for hepatitis Delta than for Hep A or or for well, really for A, B, or C. So I think, you know, if anyone who's on the line today has ideas for sources of data that we may be able to host on the HepVu site, or even Q&A blogs that we might do around hepatitis delta, we would love to hear your thoughts. And you can email us, you can send us a message on social media, put something in the chat today, but this is definitely an area that we're interested in moving into.
Right. All right. One of our next questions is, do you have an example report with prevalence estimates? I think.
So I can take a first stab at that one, Guatemala. We have been planning and talking for some time at HepVu about providing link outs to surveillance summaries that states make public, and we did ask the jurisdictions this year for links to their current surveillance summaries, and so hopefully that's something that we'll be able to work on following this report, so that people can, you know, with the jurisdiction's permission, of course, go and check out the good work that people are doing around the country.
All right. And then we have the question, why so much emphasis on one FTE? I appreciate you can demonstrate an increase in hepatitis B and hepatitis C analysis, but one staff is not sufficient to do everything CDC's grant expects.
Yeah, I can jump in on that one too. I think, you know, in the baseline year, there were so many jurisdictions that didn't even have one FTE, that's, you know, we wanted to highlight the percentage that didn't even have one, and how much more work could be done with at least one FTE. I think, you know, now that the percentage of jurisdictions with at least one FTE has increased substantially, to 80% this year. In future years, we'll be asking jurisdictions how many FTEs they have currently dedicated to core surveillance activities, and then we'll be able to stratify findings based on sort of a distribution that makes more sense based on how many staff the jurisdictions actually have. And you know, one finding that I do think is worth repeating is that, you know, as I presented and Frank sort of reiterated, jurisdictions said that they needed, you know, 3 to 5 FTEs to do the activities under the CDC funding alone. And so I think you're absolutely right, and that's something that we'll continue to highlight.
And the only piece that I'll add there is, you know, the 3 to 5 number of FTE folks would like to see for their surveillance programs. That's a number that we've actually seen since NASDAD did an assessment of prevention and surveillance needs for viral hepatitis programs. So we know that one FTE is not enough, but it's definitely great to see that we are increasing the size of these programs, but we know that there's significant growth that needs to happen. And again, working on the advocacy side to see the appropriation of increased funds to CDC, as well as increased state funding and private opportunities for funding for viral hepatitis as well. We have a comment here. A recommendation / consideration for your next assessment would be the structure of public health in the state, centralized versus decentralized. This may help federal partners, advocates, etc., have a better appreciation of who is responsible for local investigation of cases. It's an excellent point. All right, just check to see if there's any feedback there. All right.
I don't see any additional questions, and we're just a couple minutes over time, so we may want to go ahead and wrap up.
Let's.
Well, I'll just say a huge thank you again to everyone who came today. We had a great crowd as usual for this briefing, and a special thank you to my colleagues Guatemala and Frank, who I love working with, and just do such tremendous work toward eliminating viral hepatitis in their respective positions. And with that, I will say to the jurisdictions, get ready for the next survey. We hope that you'll respond and just keep on engaging with us. You see that these findings really get used. And so we appreciate you taking time out of your already overstretched workday to respond to this survey. But hopefully seeing the use of the findings is motivating for doing that. And to everyone else, check us out on HepVu.org. There's a whole toolkit that goes along with the report today. And hopefully you find many uses for these findings in your work, and follow us as we move along with annual reports, and to continue to monitor the state of surveillance activities across the U.S. Thanks, everybody.
Thanks, everyone.